Afternoon. I would like to call the Health Commission's Community and Public Health Committee meeting for today, August 20th at 2 p.m. to convene.
And I will take the roll. I'll start with you, Commissioner Dorado,
Present.
Commissioner Salgado,
Present.
and Commissioner Christian.
Present.
All right, thank you. I'll read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second item on the agenda is the approval of the July 16, 2024 committee meeting minutes.
I move. Second.
Is there any there's no public comment in the room, and there's no remote public comment. So would you like to do a all in favor?
Aye.
Aye.
Great, thank you so much. The minutes have been approved. We can move on to item 3, the maternal, child, and adolescent health needs assessment and foster care services update.
Okay. Good afternoon. Good afternoon, commissioners. Thank you for having us speak today. My name is Aileen Armstrong, and I'm the Director for Maternal Child Adolescent Health Section, and I will be speaking on our needs assessment summary. And I also have here today with me Tiffany Reyes Thompson, who is our interim nurse manager for foster care services and California Children's Services, and she will be presenting on foster care after me. So, thank you. Next slide, please. What I have here is, this is the org chart for the Department of Public Health. And as you can see circled, we're under the leadership of Dr. Albert Yu, who is the interim ambulatory care director. And underneath Albert I report to him as the MCH director. Next slide, please.
And commissioners, just so you know, the org charts aren't in your versions, but that's the only change that was submitted after the packets were delivered.
So the following org chart is the org chart for maternal, child, adolescent health. We have approximately 200 staff in our division, and as I stated, I'll be reporting to we have a vacant position. Once Albert Yu stepped aside, they have identified someone who will be taking the leadership role. And we have some other vacant positions that we will be filling before the end of this year. Thank you. Next slide, please. So today I'll be talking about our needs assessment summary and our action plan. And the state required us to work on 5 domains. And I'll be speaking to the 5 different domains that was mandated for us to speak on. So every local needs assessment includes the 5 components. It includes partnership engagement. We collaborate with various people to ensure that we collected that information. So the 5 domains is the women and maternal, infant, perinatal, child, adolescent, and children and youth with special health care needs, defined as any child and youth from birth to 20 years of age. And so there's the definition of our children and youth special health care need. And it was definitely a priority that this year we really focus on children with special health care needs. Next slide, please. The needs assessment is a process to acquire a detailed picture of the strength and weakness of the state's public health system. At our local level, our objectives in conducting the needs assessment included the following. One, to assist the health and disparities of the population we serve, specifically women, parents, infant, children, and youth and with special health care needs. Two, to inform our program's 5-year strategic planning. And three, inform planning and policies for San Francisco Department of Public Health and local partners. And four, inform our statewide needs assessment. As a result of this process, we identified the top 3 priority health needs for each domain population. We reported the additional competing priorities, which I'll be speaking on shortly, that were identified by the community. We reported the resources and strategies we used throughout our process and reported these findings from the Children and Youth with Special Healthcare Needs Assessment. Next slide, please. Our local needs assessment included the 5 components. We collaborated with 28 partners and stakeholder organizations to learn about their perspective in community health needs and to work with us and engage in community members and clients to actively participate in this process. We also worked with our population health partners to ensure that we we're utilizing the time for community, especially individuals who had to take off from work. We were able to give them a $100 gift card for their time for coming to a 3.5 hour meeting. And so we wanted to make sure that we provided some type of stipend. We also engaged with the over 200 community members and clients, including the parents and pregnant individuals, as I stated. We also utilized our data that was collected from Family Health Objective FHOP projects. We also looked at DPH's data. We pulled data from vital records. We engaged community to share their lived experiences as well. The Children, Youth, and Special Healthcare Need, this was an exciting time because we finally had the opportunity to bring in parents who have children with special health care need and engage all of the stakeholders. And this was a requirement. So one good thing is that San Francisco MCH had already started an advisory board. So it was easy for us to piggyback off of the advisory board and let them know that we're serious about meeting their needs as well. Okay. Next slide, please. So here are our top 3 priorities that we submitted to the state based on the community. We wanted to be intentional that the community voice was at the forefront and it wasn't coming from healthcare professionals. It wasn't coming from staff or, anyone that's outside of who are being impacted by the needs assessment. So this is what the community stated that as a top priority: access to care for the women, maternal child population, housing insecurity, homelessness, and mental health. Those were our top 3 priorities. And on your right-hand side, the competing priorities reported by the community were, I won't read through all of them, but it's in your package, like physical activity, nutritional health and weight, food, nutritional security, economics came up. A lot of our families are really struggling here in San Francisco. Health literacy and identifying misinformation and navigating complex healthcare systems, just to name a few. Although we reported the 3 top priorities, we still submitted competing priorities, and we will see what the state come up with once they deliver that message to us. Next slide. Infant perinatal health, the top 3 priorities. You're going to see some trends, some overlapping: access to care, economic and family support, mental and physical health came up as a priority for the infants. And on the competing side, once again, food, nutrition security, breastfeeding, parenting resources, and stable housing, homelessness as the competing priority areas. Okay, next slide. For our child health, the top 3 priority areas, access to care, hospital, and health insurance came up as a top priority, social and emotional health, and learning and development. These are our top 3 priorities for the child health. And then also in terms of competing priorities, once again, physical activity, nutrition, healthy weight, environmental, neighborhood safety and cleanliness. And then we also had health literacy and identifying misinformation, to name a few. Next slide, please. For our adolescent health top 3 priorities, we engage our reproductive population in Unified School District and various clinics where our reproductive age population get access to care. And the top 3 priority that came up for them is housing security, homelessness, mental health, and economic family support to cover basic needs. This is a young population of age group from 12 to 18 years of age that completed surveys and responded to survey telephone calls. Just to let you know, these are the top things that they identify that they would like to see something done for their age group. And then the competing priorities, once again, food and nutrition security, substance use prevention, community and social connectedness, and safety, just to name a few for that population. And then our last domain, next slide, is the children and youth with special healthcare needs. The top 3 priorities that came up is case management, navigating a complex healthcare system and related services, access to availability of specialty providers, including a dentist, and then also mental health and respite care for the family parent caregivers. Those are the top 3 priorities that came up, and that we see gaps that are not happening for our children and youth with special health care needs. And the priority competing areas is like the community inclusion and social support for the family and their child, service quality, access to care, and health insurance, to name a few. So there was definitely a lot of overlap for each domain, as you can see in the package, that needs to be addressed, and that we're hoping that other local counties, when they have reported their needs assessment, if the state basically told us if they see some overlap and some trends, they will try to have all the counties address that as our 5-year scope of work over the next 5 years. And if there are some areas that came up as a trend in the competing priority needs that didn't make it in those top 3, they will take that into consideration as well. Okay, next slide. So overall, this process for MCH was very exciting and compelling. We were able to host our large convening at 1550 Evans Street in San Francisco. We wanted to ensure that it was at the Southeast Community Center where it was accessible for transportation for folks to come and convene. We had a really great large turnout. Our next step is to, we're hoping this month to get the information from the state on what our priority areas, and we will start our planning of a root cause analysis. And that will be done strategically, really planning out, making sure we're partnering with stakeholders who have, let's just say, for instance, there's a CBO out there working on housing and the homelessness. We in MCH will make sure that they're at the table and that they get this information so that this can become a priority of addressing the needs over the next 5 years. And we'll all have this opportunity to collaborate. I have also shared this information with my director, Albert Yu, who's also shared it with our leadership, upper leadership, so that we all are on the same page and knowing that this is a priority area that will take place over the next 5 years. And I'll stop right there. And do I open it up for questions, or do I let Tiffany go?
Oh, you can get finish. Well, actually, you're the leader of the committee. I'm sorry, Commissioner.
I think we could split it up a little bit, at least for my brain to go
Yeah.
that way. Um, this was an excellent report, and I appreciate it. And as, in one of my questions, when you do receive the state report, I'd really appreciate it if you'd share it with us as well. My one question with the state, if there's competing or overlapping with other counties, is there funding attached to that?
That's what we're hoping. We're hoping that as the state, because this is driven by the state,
Yeah.
to do a 5-year needs assessment. And when there is overlapping, they will base it on each county, possibly their population, the Medi-Cal, our Medi-Cal factor numbers will probably be taken into consideration. And then also, we are definitely hoping that they will give us additional funding to support this effort. Now, if it's those other competing areas that does not come up in the state report, the question is, do the local county want to address some of those issues? And if we
Okay.
have funding to support that effort.
Well, I would assume one theme song of every single area is mental health, is, economic security and housing. They have another initiative, but I'm hoping then that at least, I would assume then across the state, that's a huge need. So
Yes.
I'll cross my
Yes, me
fingers
too. I'm with you.
that then with more funding, there can be increased not only access, but creativity
Yes.
in going forward. Okay, so we look forward to that.
Thank you for the presentation. Excuse me, really clear and very interesting. A lot of information here. I think about this often, and the answer is probably this is not really what we do, and it's not really directed toward you. So the state will do what it does, and we often are. I'll just speak for myself. I'm often underwhelmed by what they do for what they mandate us to do. And have we sought and do we seek also additional sources of funding for the programs that may be a little underfunded or not funded at all, or the overall scope? I know it's my basic understanding that we try not to rely on grants, but I just really don't understand fully what we do and do not do. And that's probably not a question for you, but I just wanted to ask that question.
Well, I will say, as we in maternal child, we tend to also look at gaps and address health disparities. And we also look at opportunities. Although we don't get a lot of grants, but the state have been able to allow our local county to use some of our funding that would support areas where we need to work on. And I'll give, for an example, Black maternal health outcomes. The state have put more dollars towards addressing preterm birth through our initiative called Perinatal Equity Initiative. And so as we looking at some of the impact to Black maternal birthing people, we can use some of those dollars to help with that population. And then also in terms of mental health, we work with our behavioral health department in DPH and ensuring that birthing people and children get access to mental health services. And just maybe our goal is to tap into some of those resources that's already there and making sure that our families get access, because access also came up quite a bit as an overlay. That means what are those barriers that's keeping them from tapping into some of the resources that we have available here in San Francisco?
That's a great point. Thank you for that.
Mhm.
Thank you for the presentation. I just have a quick question. Another topic that comes up on all the sheets is racism. So what exactly are they getting racism from, people in the health? Or is it they feel that they're not getting the medical help they need because of, their ethnic background or both?
Well, I can speak to some surveys, focus groups, when asked what are some of the, your experience, client experience is very important. A number of our programs are now starting to collect data on clients' experience, and that client experience can be anywhere from just stepping foot from the front desk to the back end. And oftentimes, just say a pregnant mom or a child with a special health care need show up to a doctor's appointment, they're looked down upon, and that can be harmed. That's harming, and that can be feel racism, and especially based on just the color of your skin. And oftentimes our family will share that information. And we do have, I think we could do a better job with the implicit bias trainings and holding folks accountable. But that's just one example of family sharing. Yes, when I show up at my doctor's office, I don't feel like my voice is being heard.
So once the family shares that information, what happens? Do they get directed to another clinic or another doctor, or because I wouldn't feel comfortable going back to the same place if I already felt uncomfortable from the beginning. So what happens then?
Well, I've spent a lot of time with a lot of the preterm birth initiative work. And when we hear information that a mom felt like wasn't getting quality care or felt like she was looked down upon, we have a community advisory board. And part of what we also learned through this through this process of a needs assessment, we need to have more robust community engagement where families are also at the table and they can share so that we can then leverage that information to our partners, working with Zuckerberg or working with UCSF and saying, here, getting this information into the hands of people who can make the changes. So that's something that we are definitely ongoing. There is a need in my section to fill some high-level vacancy positions, and I'm hoping those people will be in their seats before the end of this year and can take on some of that work.
Okay, thank you.
You're welcome.
Kudos to you for, for saying that, because I mean, I'm in the same business basically, seeing, we have so many kids in our clinic, and that is something that so many of our families, especially the kids with healthcare needs or our kids with autism, really experience. I don't know if it's racism. I mean, racism, yes, to a certain extent, but they're really looked down upon, and so it's educating staff that is so important. So I want to thank you, but I understand the challenges.
Yes.
Picking up on what Commissioner Gerardo just said, I imagine that there are some structural trainings and, meetings that employees throughout the who provide these services have to attend from time to time. And assuming that is true, do the results from these surveys get presented to people in that space? Do you know?
Not that, well, we also, in Department of Public Health, we have Office of Health Equity, who have been also engaging in helping us navigate, ensuring that we use race equity or equity through all of our work, whether it's the hiring process, whether it's through, client engagement. And my managers right now are focused on looking at how we're doing and making sure that we're providing the best quality care. And so whenever something come up, if there's a client complaint, I usually will bring it up to my, upper leadership, and then they will also look into it as well. Okay. I haven't had anything come up, since Dr. Albert Yu has been in the interim, but my prior, his prior person, she would definitely work with me. And also, if there is a situation that we could be able to mitigate some type of negative outcome, it did happen.
Thank you.
It's not an easy job.
No.
And I can just empathize with you because it's where it stops is my lap at my place. So I understand it. And what's tough, especially for families, is the most important thing in their life is their child. And if, you cross that line, it's very difficult. So thank you.
Thank you.
Go on to the rest of the presentation. Thank you so much.
Okay.
Thank you for commissioners for giving me this opportunity to speak with you about foster care. For foster care, we also call it Family Children Services Nursing Unit. You also know that it's part of child welfare. There are DPH public health nurses are part of maternal child adolescent health and contracted through Human Services Agency. So just to talk a little bit about some statistics, in the United States, there's about 400,000 foster children. In California, we're looking at about almost 60,000 children in foster care. And here in San Francisco, we have anywhere from 600 to 900 that are in out-of-home placements. And when out-of-home placements means that these are open cases within San Francisco. So it doesn't include any referrals that are coming in, but these are the ones that are becoming opened for us to follow. In my program, I have various programs. I have the Birth to 5 program, which is the field nurses who go out and support the 0 to 5 population. And then I have the healthcare program for children in foster care, which is called HCPCFIC, and that is going to be the program that I'm going to be talking about much today. A lot of the program for HCPCFIC is the case management, helping to navigate complex healthcare systems and any related issues. And just for you to know, the children and youth that we currently work with typically have higher rates of serious health, emotional, behavioral, and developmental problems compared to any children and youth in the same socioeconomic background. Next slide. So this right here, as I was mentioning to you, this is the trend of 5 years of the child welfare referrals that are coming into San Francisco. So for 2018, 2019, you could see it's about 5,500. And then during COVID, we had a drop of 4,500 to 4,533. And now this is climbing up the ladder. Our referrals are growing more and more each year. Part of this is that, the drop is that most of our children, the mandated reporters are typically our education sectors. 23% of them are education sectors. 18% of them are indicated as other or unknown. So these can be neighbors, these can be your family members, these can be bystanders that are reporting out to make referrals. And then 17% are the law enforcement, going out to DV cases, being able to see that the child is unsafe, whether it's neglect or sexual abuse. Next slide. So as I mentioned, the healthcare program for children in foster care, HCPCFIC, we provide consultation and resource guidance. We are funded by the state to support our children in foster care. The program navigates the healthcare system to facilitate appropriate referrals. Some referrals are developmental referrals, such as linkage to regional center. This can be to specialty providers. This can also be to community-based organizations and making sure that these referrals are met. Some of the supports that we also do is establishing primary care providers for medical and dental, ensuring that our immunizations are complete for our foster children, medications which are new or anything that is refilled requests that are coming in, psychotropic medications, and this is really huge. Foster children are 5 times more likely to be prescribed antipsychotic medications, which is really sad. Sometimes we're seeing children as young as 5 years old getting 2 or 3 psychotropic medications. And what we're grateful for here in San Francisco is we have a panel interview through Behavioral Health Services who look at these medications and question our, the providers who are prescribing these at a younger age and questioning them, why are you prescribing these meds? So that it's been doubled actually, where we have a lot of children on psych meds. Other additional support that we do is providing medical records, interpreting medical records for Child Protective Services, providing as referrals, as I mentioned to you, specialty visits, regional center, providing community resources offered in San Francisco, supporting our pregnant foster youth, that's the moms and the dads, along with their children. And even though these children don't have out of home or active cases, we're still supporting these children as well. And then to ensure that the non-minor dependents, and this is the AB 12 extended foster care 18 to 21, that they're readily prepared to exit foster care with all the services that they can. So at 21, they have to have housing, school, work, medical capabilities, and that's a struggle for us. Next slide. So next, I'm going to talk about some of the challenges that we have and the needs. The challenges outside of our scope, and these are the things we cannot change, is the lack of mental health providers. You can imagine that if we have a mental health referral that comes along, some of our kids don't get to be seen for up to 4 months, sometimes 5 months, 6 months. And so, we're trying to figure out resources out in the community so that these children can be seen. Challenges with placement. I shared a little bit of picture at the bottom which says, we lose a little bit of San Francisco when a foster kid and placement they're placed outside of the city. All of these foster homes and these families are moving out of the city and they're going to the Bay Area counties. And so that's pushing a lot of our kids out of San Francisco. This also impacts the lack of emergency homes. Without the stability of the mental health and knowing that these resources are available for these kids, the lack of emergency homes and these parents, resource parents, are not wanting to be resource parents in San Francisco anymore. Some of the challenges that we can change within our scope is the acuity of the cases. My public health nurses are working anywhere from 2 to 3 hours on one single medical case. So if you put that on average, that's only 3 kids that they can work on in a single 8-hour shift. Our cases are anywhere from 125 to 150 cases. We have referrals to regional center that are not being met on a timely manner. PHNs are also enrolling and disenrolling into Medi-Cal, and also making sure that our kids are on managed health plans. So with that said, our public health nurses are wearing multiple hats. We become the eligibility workers, we become the public health nurses, we become mental health providers and therapists, and really supporting our foster families. So my ask, and for your awareness, is that hopefully with the support of the city and county, if there's an opportunity of the next budget cycle, I'm hoping to get additional staffing to help with these challenges that we're seeing. The needs are very high and for this population, and unfortunately, we're not able to get everything done. And so we want to make sure that our children's needs are being met. Next slide. And just a little bit of what the public health nurses could do if we add these public health nurses to our program is act as family children services linkage coordinators. There can be some of the public health nurse that can see youth with medical complex needs. They can assist with high priority needs and being able to address those needs and referring out to enhanced case management through the health plans. Being able to identify trauma-informed medical and dental providers who know how to work with our foster children in San Francisco. And then being able to participate in child and family team meetings. These are meetings that are held from child welfare and includes attorneys, their support groups, the child, and being able to attend more of these meetings so we could fill in the gaps and know how to support the child more. Last but not least is being able to connect with other CBOs to support the needs of our foster children. I always think about 21-year-olds that are going back into society. And I think that, as we're thinking about what it's going to be like for them and trying to get these wraparound services, unfortunately, they end up becoming the small percentage of homelessness. They become the small percentage of mental health children or adults not being able to get their needs met, and then just not being able to succeed in life. And so I'm really hoping with this opportunity, we can make a change for foster children and being able to support them as their needs have become so much more higher. So I want to thank you for this. This concludes my presentation, and I'm opening this up for any questions and Q&A.
Thank you for answering my multiple questions.
No problem.
It's an area that's near and dear to my heart. But one of my questions, or that you said most mental health services are filtered by foster care mental health through a referral process placed by, protective service or CPS worker. Are the, if they're in San Francisco or wherever it is in the county of placement, does that really happen? That's where my question too about the program A Home Within, which is, where, because I participated before, it is, I don't know if you're familiar with it. It is therapists throughout the county, but it's now multiple counties and now across different locales across the country. Private therapists or, et cetera, donate time for one child to be seen at no cost. And it's been a great program that's gone on for a long period of time. But that's where I'm wondering with access, if in fact, do you have any clue if they are ever connected to this program?
So I'm not sure if they're ever connected to that program. They may be connected with similar providers, I'm assuming, but not that we directly make referrals to that specific program. Foster care mental health is usually, yes, it takes the lead for the referrals and then looks and branches out to see in all the other counties which mental health provider is accepting new clients. And with us, we are trying to have the continuity of care. We're making sure that these children don't have to repeat their stories, that they have a therapist who they'll be able to see and be
Right.
able to have that relationship with.
Great, but just for your own.
Yeah, thank you so much for sharing that.
Yeah,
I had
for
no
you.
idea about that.
Yeah, for
I
your own
appreciate-
info, look it up,
Okay.
just because if somebody's fallen through the cracks and they come back through your door,
Absolutely.
it's really very, very reputable and good. And most of those of folks like myself who do that understand foster care. So they're
I
not
appreciate it.
random people. It just might be helpful since, again, it's another free access that I'm also, like my other question to you is, yes, when the public health nurses are referring, um, then the resources, family foster parents and to follow up on the status to see if families were actually able to access services. I guess that's one of my big issues. Let's say with the regional center system, you can, refer, the family's called 5 times and they get no return phone call. But then who within the system, our system or whatever, follows up and says, okay, let me call them, blast them or whatever. It's just, I'm always very concerned about the follow-up as a missing piece for many of these very fragile and vulnerable families. So that's where that's why I asked the question.
Absolutely. Well, thank you for sharing the resource as well.
Yeah. Something that needs to, we all have to work as a team together in going forward. So, thank you.
Was that called A Home Within?
Yes.
Thank you.
Thank you for the presentation. I just have a quick question.
Sure.
You said that once they get ready to leave the foster care system, whether they're 18 or 21, depending on where they fall, you try to prepare them, to have the tools that they need. I guess I need more information regarding, don't they have the same services for adults? So why would it be so hard to give them the tools as adults?
Well, I think what the hardest challenge is that it's engaging the youth, because some of these youth have been involved with CPS for so long, they want to get out of the system. So it's also trying to, encourage the youth to stay in foster care and think about all the support systems that can help them out. And I think also just being able to allowing them to understand that it's okay if 18, you're not ready to go out into the world. We're here to support you. We have the wraparound services for you, and you'll have, the same kind of support that you had even as a minor. So it's really challenging with our non-minor dependents, 18 to 21, but also having the expectation for them to leave at 21 and just kind of figure out their life on their own.
Because I can imagine it can be very challenging because, at 18, I knew everything. So, I can just imagine what they're going through. I was just wondering, I guess I would like more information. Maybe there's a way where these kids going into adults are not like flagged, but say when they're 21 or 22 and they reach out that they do need these services, that, it's already like, okay, this was their prior history. Let's help them, guide them so that they don't feel overwhelmed starting all over.
Absolutely. And I think with something that just rolled out by Cal Ames was this enhanced case management. They are there to support, and that's where we're doing a pilot program to connect our kids to ECM services right before they turn 21, and ensuring that they're being connected and they have like kind of a continuity of case management right after they leave foster care.
Because this really hits home. I grew up in the city. I grew up in the Mission. So a lot of my friends, some people I know fell through the cracks. So I know where this can lead to. So I think if there's a way or if there's information out there where the safety net can be a little bit wider. Because
Absolutely.
I know that when you're that young, you know, you're trying to get away from everything.
Absolutely. And I think us capturing and addressing the mental health early on is probably what's going to help us and help them in the future. So being able to have, with the wonderful resource that you shared with me, being able to talk them through and getting them through mental health on any kind of trauma that they faced, they may overcome this and they may have the tools to just be successful in life.
Thank you.
Thank you.
And also, if I may interject, there's, the DPH is responsible for its catchment of services, and then there are other departments and other places in the city that might be so it's not, again, it's complicated, so it's not one-stop shopping where everyone goes to one place. Fortunately, we're all divided. Am I saying the truth here on that? That's even, right. So just to paint the picture, we're only responsible for a piece of the pie, and I'm sure we work well with others, but we're not in control of all that. So again, it's harder for those folks who are turned 21 in the world.
Multiple silos is what is so, can be very frustrating because one of my sons is from the foster care system. So I totally understand that in how I was always so confused, as a parent as well, of which system was which, and what fair was I supposed to go to and who's sponsoring it versus his medical needs and dental needs, et cetera. Okay, got that taken care of or whatever. So yeah, it can be daunting, and and we're only one piece, but then we've got HSA, we've got others who are, part of the pie. And I think that's where, oftentimes different, CBOs that I've worked with, like Larkin Street, has been helpful in navigating too.
Following up a little bit on Commissioner Gerardo and Commissioner Salgado and Mr. Morowitz's comments. One of the silos that you're probably familiar with is vocational. The city, I can't remember the name of their particular program silo, but they exist and have resources, multiple resources for people in the city. And I think they also target youth and young people as well. I don't know whether there is any programmatic or intentional linkage with some of these services and these organizations that show people, like tell people what the jobs are, how to get them, how to, get into the training programs, getting into paid training programs, things like that.
Yeah, I think a lot of our community-based organizations like ILSP or Hype Center, they are connected with a lot of the DPH programs and helping to support with those specific needs for our youth.
This one is a workforce program I'm thinking of,
Okay.
and I'll try to remember the name of
Okay.
it, find the name, but
Thank you.
mhm.
Yes.
Thank you. I just want to acknowledge the team's work and the amount of multitasking and sort of whatever it takes to address the issues. I just want to thank them for that. And also just to a through line potentially to continue to go through with the conversation around what happens as people age into another potential stage of life is for us to, when we're for future presentations, when we talk about transitional age youth, there's a place there that I'll ask staff to make sure that they sort of talk through the transition plans that are within the DPH charge to inform the commission. So both on the behavioral health side and on the primary care side, as you all know, there's a lot of work being done with transitional age youth, but I think a lot of the issues that were just brought forward are also challenges that we can talk about in the TASE space.
Thank you.
All right. Thanks
Thank you.
again.
Thank you both.
We can move on to item 4, public health emergency preparedness and and response update. Dr. Tenner.
Hello, Commissioners. My name is Andy Tenner. I'm the Director for Public Health Emergency Preparedness and Response, or as we affectionately call it, FEPR. I am so excited to be with you guys today. It's been since, I think the last time I was here was December of 2022. And our team has accomplished quite a bit, and I'm very proud of them, as you can tell from the supplemental accomplishments pages I submitted. So I appreciate the opportunity to come and speak to you all. We are certainly, we're a growing branch and we're a work in progress. And I also feel like every time I speak with the commissioners, I learn something. So I'm excited to hear your feedback on this as well as we work through. So next slide thing. Thank you, Mark. So Public Health Emergency Preparedness and Response sits under the Population Health Division within the Department of Public Health. Dr. Susan Phillip is our director. And if you'll go to the next slide, Mark. As you can see, this is the org chart for Population Health Division. So the circled box at the top is Dr. Phillip, just to orient you to where we are within DPH. And then if you will, next slide, Mark. We sit under the Public Health Services branch of the Population Health Division and work very closely with environmental health, communicable disease, and the EMS agency in making sure that our communities are prepared and can respond to health threats. Next slide, Mark. Thank you. So our mission and vision is our mission is through citywide partnerships. We coordinate evidence-based disaster mitigation processes to protect health, cultivate resiliency with an equity and community-based approach. It's a bit of a mouthful, but our job is to try to make sure that we as a community are prepared for public health emergencies or for the health aspects of other types of emergencies. We know that no matter how good we are or how big we are, we can't be everywhere at once. And so a lot of our work stems around trying to create capacity within all of our partners, our hospitals, our city partners, our communities, so that people know what to do in an emergency. This is aspirational, and we are working our way towards that mission. And our vision is really to be a trusted partner and fostering robust preparedness, culture, and response capacity. So really, we want people to look to us as a resource, and also have people really, the various groups that we interact with, to think about preparedness and response when it comes to emergencies. Over the past few years, this has come to the forefront, I think, just with all of everything that's happened. But, you know, and I think it's demonstrated some gaps in our preparedness, in particular towards vulnerable populations, which is why we highlight this here. The same inequities that we see across the health system and across society worsen in disasters. So being prepared for that and planning for that is key. The ways we're hoping to develop this through our vision are to developing preparedness champions and emergency response leaders. And again, that's across all of our various stakeholders. And designing a public health emergency response structure that makes sense and is adaptable to the various emergencies that we face. We're hoping to do that through workforce development, evidence-based planning, preparedness education training, and practiced response. And that means having robust plans, knowing that we can't plan for everything. So we try to plan for the 80% of things we know are going to go wrong, trying to prepare that so we have the mental space to deal with the 20% of the zombie apocalypse or whatever the next thing is that's coming through. And then the training and practice is really important, because we can write beautifully crafted plans, but you know, we don't realize that nobody knows where the key is to open the door that we need for whatever. So whenever we do the practice, the exercises, we kind of poke holes in our plans and try to understand where we've had issues and how we can anticipate and make those plans better. Next slide. So where we were when I came the last time, this is where we were. We had 14 staff, and we had a lot of vacancies. So we were coming out of COVID. We had the same issues that everybody else did. So we had about 8 staff. Next slide. And where we are. So we have, at this point, we have about 27 branch staff. We still have 4 vacancies, but many of those are because of promotive opportunities that we're now trying to fill. And I just want to thank everybody here for that. I think it's through the foresight of the Department of Public Health and Grant and team, through you all, recognizing that we really didn't have what we needed to be prepared moving forward, and this helps build our capacity. So half of our funding comes from federal grants that come down through the state, and we have 1 small state grant. And the other half is general fund. So that has allowed us a lot more stability as federal funding ebbs and flows. So our grants, our major grants are the Public Health Emergency Preparedness Grant and the Healthcare Preparedness Grant. We also have some smaller grants that are the Cities Resilience Initiative and the Pandemic Flu grants that come, again, they come from the state, come from the federal partners through the state. And then we also have 3 support staff that we've supported hiring in other branches, and 24 staff have either been promoted or hired since December of 2022. So this is a huge effort. My whole team was involved in this, really trying to move hiring forward. And I have to mention the PhD hiring task force, in particular Daisy Aguayo and Christina Sanz Rodriguez in Population Health Division were instrumental in helping us to move things forward and really hire these positions. It's been a flurry of hiring. I've learned more about HR than I ever thought I would know. But we have got a really incredible team with a lot of diverse backgrounds and skill sets and experience. And it's been really great seeing our strategic planning process, bringing that experience in and getting different perspectives and being able to grow. So thank you. Next slide, Mark. Okay, so some of our major accomplishments to hit the highlights while we were hiring. Next slide. So we had one of our staff, Tiffany Rivera, was deployed to support Laguna Honda's emergency operations program. And then we had several other staff that helped her in that response. From the time she was deployed, we had 3 state and federal surveys with 0 emergency preparedness negative findings, which was huge. So this was obviously a huge effort across the entire department. We were very happy to be able to contribute to that and appreciate Tiffany's work on that. We did, as a part of that, we updated the emergency operations plans. We worked on emergency evacuation plans, distributing emergency evacuation supplies throughout Laguna Honda, and then did some training of staff and had a facility-wide evacuation exercise. Next slide. Additionally, we supported the DMAC, the Drug Market Agency Coordinating Center. So this was an initiative in response to overdose responses. The overdose crisis that we were facing. I served as the DPH lead for the initial coordination and helped to coordinate between behavioral health services, jail health, our hospitals, and then with our citywide partners, including our field services, our street response teams, our behavioral health support street response teams, and coordinating with police, with HSA, with HSH. Under this work, we developed a multidisciplinary street response team that included public safety, public health, and our various teams, as well as CBOs, to really go block by block and try to work with the people that we were finding to figure out what their needs were. Did they need, if they had health needs, if they needed referrals to our behavioral health access center, we could get them in there. If they needed housing, we could work with HSA and HSH to get them on the list for housing. So it was a nice coordination of effort that came about as a result of that work. Next slide, Mark. APEC, the Asia Pacific Economic Cooperation Summit. So this was designated as a national special security event. This was the largest gathering of international leaders since the UN Charter was signed in, I think, 1945, sorry. So we had delegates and leaders from 21 member economies. When something is designated a national special security event or an NSSE, the planning is led by the U.S. Secret Service. Federal, state, and local partners are all included. To give you a sense, there were 21 subcommittees. We were a part of the medical health subcommittee and led the health planning components. When we started working on this, we realized we needed to have a robust playbook for all of the different health threats. So we developed a playbook and some hospital guidance tools that have now become the standard, and the Secret Service has deployed them for the Republican National Convention, the Democratic National Convention that's happening right now, and we've been discussion with LA around planning for the Olympics. So, it was a huge amount of effort, but again, I'm so proud of not only my team, but we had environmental health. They were, morning to night, working with the food providers at the events, and got trained in food security and really did an amazing job of being there and protecting. We had, scanning for health threats. We were working very closely with communicable disease, environmental health, and my team. Really, it was a great opportunity for us to all come together. Also working with the Health Commission and the regional, not Health Commission by proxy, but our hospital council and our regional partners as well. Some of the activities we did, we created a GIS map of all San Francisco healthcare facilities, so not just our hospitals, but our pharmacies and other partners, and that was crucial in identifying sites that might be impacted by the footprint for APEC. We had seminar and tabletop exercises with DPH partners, as well as with our city partners, with some of the hospitals and other groups, with Secret Service, with the state, with the ASPR, the They just changed their name. The Administration for Strategic Preparedness and Response, which is our federal HHS partners, as well as CDC. Next slide, please. Right, and Operation Encore. So this was what we called what we call a full-scale exercise. So a full-scale exercise is like what you might see on TV, where we bring in actors or volunteers that get moulaged. Moulaged is the process of putting on fake injuries. It's very intricate. It's very impressive. So some of the stuff that they were able to make. But this was really the culmination of about 18 months of planning and of smaller exercises leading up to this. So we were tasked from our HPP grant and the HHS side of the house to do an exercise that overwhelmed our adult hospital bed capacity by 20%. So we had over 400 patients. We had over 200 actual players. So we did have some hospital sites where we had stuffies with patient cards on them that were treated as patients. But we had about 120 fully moulage volunteers and 85 exercise support staff. So that's controllers, people that were kind of running the project. We had this at San Francisco State University. And it involved all of our major EMS partners, all of our EMS agencies. It involved the Department of Emergency Management. We had 12 hospitals that were involved in this as well. And let me see if I forgot anybody. Our communications were involved, our 911 operators. And on top of this, their system went down at like 5 a.m, but they were able to get it back up and still participate in the exercise without a hitch. And so that was really impressive work. We had 35 planners from over 17 agencies. Next slide, please. So what you can see here are some of the agencies and the players. I think our participants probably had the best time. We had some really great Oscar-winning acting skills through this. But we actually had, the scenario was a bomb or an explosive device that went off at a concert. We had pyrotechnics and lighting for that. And then we had our agencies actually come in, pull the patients out, triage them, and simulate getting them onto ambulances. We didn't actually transport because of the logistics involved. But then at the hospitals, we had controllers who, when somebody was loaded into an ambulance, if patient A was loaded into an ambulance, there was somebody else at the hospital who was also patient A and would be told, now it's time to come in. And so we were able to simulate that quite effectively. Next slide. And then just the support that we had. This was all the leaders from the different agencies that came and were observers at the site because their agencies were participating. And this picture includes our local partners, DPH partners. We had our city partners. We also had HHS federal partners. We had California Department of Public Health was here. We had some industry partners that were working on some of the tracking software for the EMS agency. So we had quite a few people that were involved in this exercise. Next slide. Also, we led the team, the incident management team, for staff and contingency planning as a part of that. So obviously this is something we worry about. If staff cannot come in, what are the essential life-saving and life-protecting activities that we as a department need to cover? And that can be for a variety of reasons. Something like a labor action, or the bridges go down for something. We have a big earthquake and there's debris in the streets. So this was a DPH-wide effort to update our continuity of operations plans for every branch of DPH. So essentially what we did is we looked to say, okay, over these different time frames, what staff would you need? So if it's a one-day event, there are some things that you could put off for 24 hours, like dialysis, for example. Somebody could miss dialysis for 24 hours. But when you start hitting 72 hours, you need to be able to operate your dialysis centers. So we looked across the branches at what activities we needed to continue, and then what staff we needed, what kind of training, what are the job classes. And then we developed a dashboard that shows the areas that are open, what we would need, and also, as an example, if my job class is a 2233. So if you need 2233s, where are other 2233s within the department? So, and then do I have special training, or there's special training that they would need to fulfill my role if they needed to step in, so that it makes it a little bit easier for us to navigate and try to make sure that we can move staff to cover essential operations in an event like this. Next slide. Okay, our community health resilience team. So when I was here in 2022, this was a twinkle in my eye. We had gotten the approval for it, but we didn't really have the staff. We had one staff member. So we are now fully staffed, which is 4 staff, and 4 very energetic staff, which has been incredible. So just as some information, the community health resilience team is really we had community partners working in FEPR pre-COVID, but in COVID, we realized our mantra that you can never have too many friends in an emergency, and in an emergency, it's too late to make them. So this is really around reaching out to our communities to understand what the needs are in our communities, and to be able for people to know who we are when something happens, and to start to understand where their gaps are, what they identify as gaps, giving advice on best practices, and really working together to try to figure out how we can force multiply if there is a disaster. So we've been fully staffed for the last, I think, 4 months now. So they're still pretty new staff, but they are learning very quickly. So in the time that we've worked, we've had a couple of staff that have been here for about a year, and then we finally we hired the last few staff recently. But in that time, they have also been very busy. So they've been learning and actively working. So we participated in 4 community events so far this year. We updated and expanded our communications list to have over 600 agencies. So this is who we let know if we know that there's going to be heat emergency, or we have a warning about storms that are coming, or for APEC, the groups that we reach out to let them know. So we've updated that list. And then what we are hoping to do is we are starting to implement a pilot program in Visitation Valley and Sunnydale. So we are, the goal for this pilot is to, one, understand how this community wants to be messaged, or how they best receive messaging. And the second is identifying gaps for preparedness. And some of those are going to be health, some of them may not be. And so we'll be working with other partners. We are trying very hard not to reinvent the wheel, and to work not in our silos of excellence, but really work across the city. So the goal for the communications work is to both figure out in Visitation Valley and Sunnydale the different populations and the different identity groups within the community, how they prefer to be communicated with, but also for us to understand how to ask those questions and how to get that information. And what's the best way to interface, because we're hoping to be able to roll that out then in other neighborhoods. So as a part of this work, we are working on contracting processes with a consultant group. We are developing matrix and data collection processes as well for this. And we're partnering with the Samoan Community Development Corps in Sunnydale, which was through our work with the Office of Health Equity. They helped us to identify that. And then within PhD, Asa King is our community health director for the deputy director. And so we've been working with them very closely to also make sure that we're coordinating with other groups within PhD and making sure we're coordinating across DPH and with other city partners. Thanks. Next. Okay, and then this is just the summary of some other accomplishments. Next slide. So we have just recently brought climate health into FEPR as well. That happened last week, so that is hot off the press. But part of that is because we have managed 12 climate activations in the last year. So we work very closely with Climate Health, and so it made sense for us to partner with them. And climate change worsens almost all of our hazards. So having that expertise within our branch is going to be very helpful. We also launched a new Healthcare Coalition outreach program. So that's a part of coordinating our healthcare partners. We have developed and delivered 30 projects that are involved around exercises and, like I mentioned, poking holes in our plans to try to make them better. We also, now that we are staffed, we have a 24/7 FEPR duty officer program. So there is a single point of contact that somebody can call 24/7, and we have a response team. So the goal for that is that the response team can handle some of the minor emergencies, and we can maintain our own continuity of operations during that time. And then we also absorbed the Medical Health Operation Area Coordinator Program, which is how we manage mutual aid throughout with the region and the state. And with all the new staff coming in, we implemented a staff development program to try to really help to support them and to make us as good as we can possibly be. Next slide, Mark. Just quickly, a few challenges. So the healthcare preparedness funding is one of our grants that comes from the federal agencies, and HHS has been delayed in getting our grant requirements out. But we've been able to navigate that through other funding streams in the short time, and then they just were able to release those funds. The biggest issue is we don't have the grant requirements. But one of the nice things about now having the bigger staff is that one of our goals has been to move from being responsive and putting out grant deliverable fires to really thinking strategically about how do we meet the deliverables of the grant, because they are sort of a basic minimum, but they're not necessarily, we may need more in certain areas in San Francisco. And so how do we work across that? So I think right now, my team is actually in strategic planning, and they're mapping out our projects so that we can be a little bit more strategic about thinking through those issues. So I think for us, this is actually much less of an issue than it is in other counties, because we're planning to go above and beyond anyway. So we should be able to meet those requirements when they're released in October. Part of this is just all the new staff working to get them oriented. We have staff that have a lot of experience in health realms, but not necessarily in emergency preparedness and response, and orienting to a new structure. So we are we joke that we're always in a pilot program, and we're doing continuous improvement right now and trying to figure out what works and what doesn't. But that has been a group effort. We have a pretty flat org structure within our department. And so we have several mechanisms for gathering feedback, and we've been able to adjust as we've gotten ideas from staff about things we can do better. And then I think one of the other things is that with all of these responses, over the past 4 years, we've identified 420 areas of improvement. We have been able to address about 140 of those, but every time we have a new response, we get more. So I think part of our strategy is looking at how can we most effectively start to target those areas of improvement so that we are addressing those hopefully as fast as we're identifying new ones. So that's, I think, going to be that's a big focus area over the next 6 months to a year. Next slide. All right, so just a few future plans. We're continuing to work on our improvement plan items, as I mentioned. We do need to update our hazard response planning. That happens every 5 years, so we'll be doing that to just look at the landscape of where San Francisco is now and what are our biggest threats. We're working to strengthen our capacity and workforce development and our capacity to respond. As I mentioned, building those relationships with community members, integrating climate health into emergency preparedness, and then supporting climate health mitigation activities. Next slide. Thank you so much for indulging me. As you can probably tell, I'm very proud of my team and the work that they've done, but I really appreciate you guys letting me come and present this information to you, and I would love to hear any questions or anything that I haven't addressed.
There's no public comment, Commissioner, so please feel free.
Wow, you should be extraordinarily proud of your team. This is amazing work. The detailed and thoughtful and visionary management and continuous building out of the program is really impressive. And so one of the questions that just popped into my mind is, this work is about disasters in part. And so what is the coordination with National Guard, state and local infrastructure
Yeah.
of that kind?
No, great question. So, you know, you can never have too many friends applies to those groups as well. So I think we have worked very hard over the last few years since I have come into FEPR. And this was, I think, something that was on, you know, was a team priority before I got here as well, to try to break down some of those silos and barriers between the different agencies. That was one of the silver linings of COVID, was, you know, all of us being together in that COVID response. We got to meet people that we maybe normally wouldn't have been able to meet. So that was really helpful. There is still a big divide between public safety and public health. And the National Guard and other response organizations being on the public safety side. You know, for example, we'll hear about a radiation emergency scenario that's happening the day before it's happening. And we're like, you should probably be there. And it's mostly, it's not even, it's just an oversight. I think people, what my experience has been that people give us a lot of credit, which I appreciate, but we still need to drill and practice. So one of the things, I went to the Center for Homeland Defense and Security Executive Leaders Program and was able to network with a lot of our federal partners. You know, I have now friends at the Coast Guard, and I'm now on the Area Maritime Security Committee for the Coast Guard to try to help make sure that we're integrated and we can provide expertise when they need it. We also get a heads up. Part of this was, you know, the Grand Princess cruise in COVID really like those kind of relationships are really important. I have sent several staff. We had one other staff who's done that within the Center for Homeland Defense and Security program. We've also sent staff to Harvard's National Preparedness Leadership Initiative, and there's a Harvard program that's on crisis leadership. Again, with the idea of both gaining skills and networking and meeting the people that we need to meet, and understanding, you know, most of the conflict, in my opinion, that arises during these types of events is we just don't understand what the other one's doing. And so we've really been working to try to strengthen those relationships. At the CDPH Emergency Preparedness Training Workshop, we actually presented on our APEC work with one of our Secret Service partners and the State Department Diplomatic Security Service partner. So we've really been trying to help to build those relationships. National Guard, we have to go through the state and then our federal partners to request them. But knowing the people along that route helps quite a bit, and understanding both when it's appropriate to request and then facilitating that request along. So it's definitely a work in progress. I think we're not there yet, but we are trying to help build those networks and really understand how we can respond quickly, because we have to make decisions pretty quickly about who we need and putting in those requests because they take time. So that is part of our staff development and training, is really building those bridges.
You would think that their infrastructure might be have been made more robust by COVID and all of these things, and so that they, you know, maybe think more quickly that, oh, if this is likely to produce people who are hurt or who are may be harmed, so we have to just build that into the fact that we're being asked to go to this thing, or we will be required to go to this thing if it occurs, this kind of thing if it occurs.
Yes, definitely. And I think that was another silver lining of COVID, is that people are starting to think about that. Even just, you know, the initial APEC planning meeting, I got kind of a cryptic invite and wasn't really sure what I was going to. But I showed up and I was the only health person in a sea of public safety responders. And but the fact that I was there meant somebody thought about it.
Mhm.
That was definitely my, like, sitting in that meeting, it was my, we're going to need a bigger boat moment, realizing what we were going to need. But But, I think that helps, just having someone, I don't know that a few years ago that they would have thought to even have anybody from health there. So I think, we are coming closer together and we're starting to think about how we can support each other more.
You mentioned a street team that, which one?
Yes.
What's the name of yours?
Well, it's not mine. It's the Best Neighborhoods team.
Okay.
I, I have learned so much about so many things I didn't think I would ever know in the past few years. But being brought into DMAC, I worked very closely with Krista Gata and Dr. Cunnins to think about how we can operationalize this and how can we really try to get resources on the ground where people need them in a way that is easy to operationalize. And so Krista actually was the one who told me about the need for this and had the vision for those street teams. And then, my role is usually being the convener and trying to pull everybody together. And so we worked very closely with the police department who, to their credit, when we brought this to them, I think saw the value in it very quickly and helped us work to get both our, again, public safety resources, the health resources, and then pulling in the community-based organizations as well.
Well, those teams are just amazing and so transformational in many ways. Thank you for this work. It is really stunning and it puts a big smile on my face. Thank you.
Thank you.
What a difference from 2022. Congratulations. I mean, this is great work, but I'm still going to plug for pediatrics.
Yes,
I
as you
know.
should. Actually, you told me, you were the one who
Yes, I
told me
was.
about the Pediatric Disaster Coalition and Patricia Frost. And I met her, right? It was probably a month after that. And I saw her at something. And so I was like, oh, I got to go. So I went
know.
over and introduced myself.
Oh,
So
good. I'm
I
glad you
appreciate it.
did.
Yes.
Yeah, disasterologist. I've never heard that term, but that is what she is known as, is that. So it was quite, yeah.
She's great. She's such a wealth of resources and knowledge. And it's been, so thank you. That was kind of what I was referencing the last time I was here. I learned a lot because I'm always trying to put together the pieces of who's there.
Yeah, and she's local,
Yes.
which is really helpful. And yeah, it's great information. But I'll
Mhm.
give you one more.
Yes, okay.
Free. How's that for you? Okay, it's a website and it is called disastershock.com. And it is in all transparency, I'm part of it. So, but it's a global organization with people all over the world. Everybody's a volunteer, but has developed information for teachers, parents, and children in a disaster. And the information is, typhoons from earthquakes. We've had the information. It's very active right now in Ukraine.
Mhm.
We've got members, head of the teachers unions in Ukraine as part of it. But all of the material that's on the website, there's some creative, art and different activities. But some of the basic information, it's all free. It's all downloadable and it's in 27 languages.
Okay.
So
Thank you.
it's a great
Free 10
resource.
languages solves a lot of our issues.
Yeah, and this is like 27 of them in African languages I never heard of. But if you're ever interested in even attending, we meet once a month and it's just interesting. It's all Zoom.
Mhm.
You or any of your staff would be welcome and I'm happy to make the introduction. It's a free resource and the focus is disasters and it was developed in response to COVID.
Perfect. Great. Thank you so much for that.
So,
And I appreciated your questions about, in particular, the schools because that is something that's on our list. And what we're hoping to start with is in Visitation Valley and Sunnydale as a part of our community efforts. looking at the schools there. And I will say, as you know, I've been in San Francisco 10 years, but I don't have kids, so I definitely don't know the schools as much. But just from my 5-year-old niece running in and telling me I had to stop, drop, and roll and everything about fire, like I know, you know, and we know that kids are a great way, educating kids is a great way to build community resilience. So that is something that we're hoping to be able to build off of as well. And this would be really great as a resource for that too.
Yeah, I think it would really help because, you know, we've seen so many kids with the drills that they have, which is great. But where I think your expertise could help is they don't prep the kids enough
Mhm.
on, you know, especially on a social emotional health basis, et cetera. And we've had to then refuse to go back to school because they've had, you know, panic attacks and is it really going to happen? So
Mhm.
it's your expertise within that education that I think within the community resilience teams could really be helpful rather than just an, you know,
Yeah, don't want to.
off the grid, you know, drop and roll, or the worst is the barring of the doors and the shooting.
Yeah, yeah,
So
no,
that
that's great.
would be great. So yeah,
Yeah.
that's where I am concerned about SFUSDs.
Well, and, you know, I just got back last week. I was at a CDC training, nuclear detonation, which I know it's terrifying, but it actually, of all of our hazards, it is the most preparedness forward hazard because you have 10 to 15 minutes to get people inside and get them in appropriate shelters. And that, you know, and you have to stay there for for 12 to 24 hours. So it, you know, and that's the difference between hundreds of thousands of people dying and saving hundreds of thousands of lives. So it's the most extreme case. But it's also portions of the planning for that can be used for a major earthquake, any kind of infrastructure collapse. But one of the key pieces there is that, you know, parents are not going to have enough time to go, if something like that were to happen, to go and get kids from the schools. So making sure the schools are prepared, the parents know, they trust the schools, they know that their child is going to be taken care of. And that would apply to a major earthquake or to other, you know, anything that makes the roads impassable. So I think that, you know, that is a key portion and just feeling comfortable as a, you know, as a parent, feeling comfortable that your child is going to be taken care of and knowing what those steps are. And for schools, obviously, you know, nobody wants to think about these things, but how do you prepare? And giving people also that hope that there is something, it's not, you know, these are terrifying things to talk about, but there are things we can do that can save lives. And that's the important thing to focus on.
No, I appreciate that because I'm on a list for a few family members and I get the, um, buzz on my phone for their drills,
Yes.
so, which is great.
Yeah.
But I just am concerned too with
Yes.
what you're doing to really infiltrate the schools would be great. So
Oh, that's great.
I
Thank
really
you.
appreciate that.
Thank you.
Any other questions, commissioners? No,
Sure.
well, I always appreciate listening to your update and I'm glad you connected with. Yeah, because I'm on that national coalition on the, it just beeped for the next one. So, yes.
Well, that's great. And thank you. I got another pearl coming out, so I appreciate that. But
Okay.
thank you guys so much for your time.
Thank you.
Commissioner, can I just add, I just,
Please.
with regard to Dr. Tanner's work, I just wanted to reemphasize the Operation Encore work. That was the drill that was done several months ago. And that, I mean, it was in the slide, but just to emphasize, that's the longest drill San Francisco's had for over 20 years.
Wow.
And just the, you know, the fact that it was pulled off in a way that was meaningful and people learned so much. And there were lots of different parts to it. It was not just DPH doing that work. It was the other healthcare systems. There was a lot of other partners. So I just want to acknowledge Dr. Tenner in that because DPH was the lead in that effort. So just to reiterate that, given, you know, we need to be ready as possible. So.
Absolutely. Thank you so much.
All right, commissioners, we can move on to emerging issues. Hearing none, we can go to public comment. There was nobody in the room from the public for this meeting. So consideration for adjournment is in order, commissioners.
So moved.
Second.
All those in favor?
Aye.
All right, thank you so much. Give me 30 seconds to turn off the recorder. Thank you. Thank you, everyone who's watching, who's going to watch in the future.